Bismillah ar-Rahman ar-Rahim, all dear students. The topic of today is about allergic rhinitis, presented by Dr. Hosam al-Sisi, Assistant Professor of ENT. Allergic rhinitis is a common clinical disease consisting mainly of an immunoglobulin E-mediated hypersensitivity inflammatory reaction of the nasal membrane. It's characterized by the symptom complex, consists of one or many combination of sneezing, nasal congestion, nasal itching, and rhinorrhea. This is the main symptoms of the allergic rhinitis. According to the time of the complaint, it may be in some seasons where we call it intermittent allergic rhinitis, maybe through the whole year, where we call it persistent or perennial allergic rhinitis. According to severity, we may classify it into mild, moderate, or severe disease. And about the causative allergen, it's mostly inhalants, like the house dust mite, this is the commonest one, sometimes molds or pollens or others. The food allergy sometimes cause the problem, like eggs, strawberry, chocolate, or others, or to less extent, some kinds of drugs. How allergic rhinitis happen? When we look to the pathophysiology of this disease, it's happened in some susceptible individuals. They are genetically predisposed. When they have the first exposure to the allergen, sensitization and production of a specific immunoglobulin E happen. This immunoglobulin E coat the surface of the mast cells in the surface of the nasal mucosa. Then on re-exposure, the immunoglobulin E mast cell complex release some immediate and delay chemical mediators. We call this the immediate phase and delayed phase of allergic rhinitis. In the early or the immediate phase of the reaction, the mediators are mainly like the leukotrienes and the prostaglandins D2. They are mainly responsible for the symptoms of rhinorrhea, like the congestion, sneezing, itching, the eye symptoms, the ear symptoms, and the postnasal drip. While in the late phase response, which usually happen few hours after the immediate phase, there is recruitment of some inflammatory cells like the neutrophils, the eosinophils, lymphocytes, and macrophages, where there is a continued inflammation lasting sometimes for hours or days, where more congestion and mucus production rather than sneezing or itching. For diagnosis of the problem, the symptoms, as we just mentioned, sneezing is characteristic for the allergy, running nose, the congestion in the nose or the block in the nose, itching either in the nose, the eye, the ear, and the palate, postnasal drip, where the discharge just drip back to the nasopharynx rather than the anterior rhinorrhea. And sometimes there's some facial features which are not mandatory to be in all patients. About the facial features, we mean the allergic shinners and the allergic salute. Shinners are dark circles around the eye. They're mainly related to the vasodilatation of the related vessels, while the allergic salutes is a horizontal skin crease over the nasal tip, happen by frequent rubbing of the nose due to itching inside the nose. When we examine this patient, whether it was the anterior endoscopy or using the nasal endoscope, we usually found a turbinate mucosa swollen and have a pale bluish gray color. The color actually is different from one patient to another. Sometimes it's pale, sometimes taking the violet color or intermediate degree of colors between them. And about the secretion of the nose, they are mainly thin and watery, which characteristic for the allergic rhinitis. For making some investigation of this, we have three types of investigation. The skin sensitivity test, they are mainly old method of investigations. The nasal challenge test, and more recently the blood test. The skin sensitivity test, like the skin prick test, they detect the possibility of which allergen is responsible for this, while the nasal challenge test consists of smelling sprays of the suspecting allergen and watching for the production of the symptoms. About the blood test, they are mainly the total immunoglobulin E amount, the radioallergosorbent test or the RAS test, and the specific immunoglobulin E levels. How we treat allergic rhinitis? We have four pillars of treatment. The first is allergy avoidance. The second is the drug or the pharmacotherapy. Third is the immunotherapy or desensitization. And lastly, and less commonly, the surgical method of treatment. For the allergy avoidance, which is practically not very effective way actually, and pollens, which is a seasonal way of affecting the allergic patients. Getting away from the suspected areas is the method of avoidance. For the patient who's for the patients who are sensitive to dust, it's advised to use the vacuum cleaner, changing the filters of the air condition, using the face mask where there is a lot of dust in the house or something, washing the bed in hot water, using the pillows which are made of polyester and putting a plastic cases on them rather than using the foam or the feather pillows. For those patients having pets, it's better to avoid and not having pets anymore because they are the continuous source of production of allergy in these patients. This is the first item, which is allergy avoidance. If you look to the drugs used in treatment of allergic rhinitis, the antihistaminics is very important line of treatment. They are more effective against sneezing and itching rather than the congestion and nasal block. We have the topical antihistaminics and the systemic or tablets antihistaminics. The topicals are less effective than the topical steroids, which we will talk about later on. About the oral antihistaminics, we have the sedating type, which is the old first generation. They are very effective, but unfortunately, they cause a lot of sedation. And we have the second and third generations, which are called the non-sedating antihistaminic, which is more commonly used through the last decades. When we talk about the decongestant, we have the topical decongestant and the systemic decongestant. Both of them cannot be used for long-term treatment. The topical decongestant are very effective, but they cause what we can call the rebound vasodilatation or rhinitis medicamentosa. So they are not advised for long-term use. The systemic decongestants mainly have the pseudoephedrine as a component. They are working as alpha blockers, but they have some side effects like prostate enlargement, like hypertension and others. So again, they are not welcome for. The topical nasal steroids are very important. They are very commonly used. The systemic absorption of them is almost negligible. The mode of action of them, they make the nasal mucosa in hospital side for the mast cells. They also block the synthesis of leukotrienes and prostaglandins and prevent influx of the neutrophils in the late phase. Some examples of them are fluoticanase, the budesonide, and less commonly the beclomethasone, which is not welcome to use in this era. The immunotherapy could be effective, but when the allergens are limited, and it's advised in the cases of persistent, moderate, or severe allergy. They elevate the immunoglobulin G and suppress the immunoglobulin E antibodies in these patients. It's advised when we have limited number of allergens, like 2 allergens or maximum 3 allergens, and they are not working if they have multiple allergens or a lot in mild conditions. The last type of treatment is the surgical treatment. We only resort to this type of treatment in 10 or maximum 15% of patients with allergic rhinitis. We resort for this surgery if we only the patient get failed in response to the medical treatment. We have two main lines of surgery. The first is reduction of the inferior turbinate. We all know that The allergy causes hypertrophy of the inferior terminal, causing nasal obstruction. So many forms of turbinoplasty are performed in these years for relief of the nasal block for this patient. And the second type of surgical intervention is doing the endoscopic sinus surgery, especially if we have associated nasal polyps with the allergic rhinitis. Then we have the vasomotor rhinitis, which is a variant to the allergic rhinitis with a different pathophysiology. By definition, it's an abnormal reaction of the nasal mucosa to non-allergic factors. The etiology of this, it's usually environmental factors like dust, like tobacco, like significant changes in temperature, either low or high temperature, and also in divergent humidity changes. Sometimes we have endocrine factors like pregnancy and hypothyroidism. Some drugs, like the antihypertensive drugs, like the contraceptive pills, and the use of long-term use of the topical decongestant in a condition known as rhinitis medicamentosa, could be all predisposing factors for this. Also, emotion and stress can cause the vasomotor rhinitis. So it's by mechanism, it's a parasympathetic overactivity causing vasodilation and increased secretions by all this etiological factor we just mentioned. Clinically, we have some symptoms like we find in allergic rhinitis, but more toward the nasal obstruction, which is usually bilateral, alternating, and intermittent. The rhinorrhea and itching and sneezing in a less extent. Rhinorrhea is usually bilateral, watery nasal discharge. When we use the laboratory test of the allergic rhinitis we just mentioned, we find it negative for the patient with vasomotor rhinitis, and this may be the differentiating point that help us in diagnosis. For treatment, we have two lines of treatment. First, in the medical treatment, we use the anticholinergic drugs, either systemic anticholinergic, but unfortunately has a lot of side effects. The topical form, which is the ipratropium nasal spray, is more effective and less hazardous in use. The use of decongestant, either oral or systemic, also can help in this condition, but with a lot of side effects, so they cannot be used for a very long-term use. Talking about the surgical treatment, which is selected for the patient who are not responding to the medical treatment, we have two types of surgical treatment. The first is inferior turbinate reduction, which may solve the problem of the nasal block and nasal obstruction. Here we do partial turbinectomy by different turbinectomy or turbinoplasty procedures. And the second line of surgical treatment is what we call the posterior nasal nerve neurectomy. This is a selective form of the old operation of the video neurectomy with less side effect on remote areas. The posterior nasal neurectomy directed against the posterior nasal nerve, and it mainly work against the rhinorrhea and the sneezing in the resistant case as we just. Then we move to the nasal polyps. Nasal polyps is a benign, semi-transparent lesions. They mainly arise from the mucosa of the nasal cavity, in the middle meatus or in other areas, or coming from inside the paranasal sinuses. They consist of fluid-filled sacs, which is composed of edematous tissue and some infiltrating cells. These cells, including mast cells, eosinophils, lymphocytes, plasma cells, and surrounded by ciliated airway epithelium. The actual pathophysiology of production of nasal polyps is unknown, but we suspect that it's a manifestation of chronic inflammation in the nose So we are not considering this as a disease by itself, but is a physical finding in many conditions or associated with many diseases. The following diseases may be associated with nasal polyps, like the allergic rhinitis, the non-allergic rhinitis with the xenophilia syndrome, in fungal sinusitis, specifically in allergic fungal sinusitis, in chronic rhinosinusitis, in bronchial asthmatic patients, patients with cystic fibrosis, or patients with primary ciliary dyskinesia, or patients with aspirin intolerance. In all these patients, we may found associated nasal polyps. Clinically, we find the nasal polyps like we can see in the picture in the right side. Um, this is the picture of the polyp, and the symptoms are the following. If the polyps are so small, they may not cause any symptoms, but if they are enlarging and protruding to the nasal cavity, they may cause nasal airway obstruction and rhinorrhea. If they are affecting the olfactory part of the nose, may cause hyposmia, may cause anosmia. Also, by the secretion that transiting from the surface of the polyp may cause postnasal discharge. They may cause headache, they may cause snoring. Also, in extensive cases, they may cause obstructive sleep apnea syndrome. When they are proliferating and when they are filling the nasal cavity, they may cause significant nasal obstruction and causing obstructive sleep symptoms and chronic mouth breathing. By examination, the clinical picture of nasal polyps. When we first talk about symptoms, the small polyps may not cause any symptoms, especially if they are not obstructing any part of the nose. But when they get proliferated and present in larger surface area in the nose, they cause nasal airway obstruction. They can cause rhinorrhea with associated discharge from their surface. If they obstruct the way to the olfactory fibers, they cause hyposmia or anosmia. They are also responsible for postnasal discharge, maybe watery, maybe mucoid. They cause headache by obstruction of the nasal sinuses. They may cause snoring with significant nasal obstruction, also obstructive sleep symptoms and mouth breathing. With examination of the polyps, their structures consist of a neck or stalk, then fungating lesion coming from them. These lesions or polyps appear as a smooth, gray, and glossy lesions. When we palpate them, we found them like soft and mobile and not tender. They are mostly bilateral. They are variable in size. They are usually multiple, a lot of polyps in each side. The usual side, they start from the middle meatus, but when they are extensive, they fill most of the nasal cavity. They can also causing ear problem. So if we examine the ear, we can find middle ear effusion when they causing a block of the sticking tube. The diagnosis of the nasal polyps depends on the clinical evaluation of the patient, and the CT scan is the gold standard imaging choice. The CT inform the presence of lesions in the nose and paranasal sinus. It differentiates this from sinusitis or other similar nasal lesions. It defines also the site of the polyps and the extension in the nose, in the paranasal sinus, or sometimes in the nearby structures. So the CT scan is very important in diagnosing the patient with nasal polyposis and for follow-up the treatment of these patients. The treatment consisting of medical and surgical lines. About the medical, the steroids, we have the oral steroids, we have the topical steroids. Using oral steroids is very effective. It's used in short courses. Mainly the course is for 2 weeks, maybe repeated for twice or 3 times maximally. And then look for the effect of the steroids. It can be very affecting and causing what we call the medical polybectomy, maybe comparable to surgery sometimes. Using the topical nasal steroids, they can affect the symptoms, can make relief of nasal obstruction in limited polyps, or using after surgery as a secondary treatment. Patients who failed the result of the medical treatment, or sometimes when the medical treatment is contraindicated for the patients, we cannot use steroids in patients for some comorbidities, we then resort to the surgical treatment. The surgical treatment, which is endoscopic sinus surgery, the ESS, include removal of the whole polyps and opening the ostium of the sinus, widening the sinuses using metal antrostomy, which is widening the ostium of the maxillary sinus, doing also ethmoidectomy, which is removal of the septa inside the ethmoid sinuses, the anterior and posterior ethmoid sinuses, doing also frontal recess clearance, which is clearance of polyps from the frontal recess of the frontal sinus, and lastly the sphenoidotomy, which is also widening of the ostium of the sphenoid sinus. So these 4 components consist the endoscopic sinus surgery for the allergic nasal polyps. But unfortunately, recurrent is not uncommon in patients with nasal polyps, and there's actually a lot of factors may afford for this. Some of them in the disease, or in the patient, or in less efficient surgery. The antrochoanal polyp is a peculiar type of polyps. It's a unilateral, coming from the antrum or the maxillary sinus. So it's a single polyp arising from this sinus and then protruding into the middle meatus, then to the nasal cavity, and moving posteriorly through the choana to appear in the nasopharynx in the late or neglected cases. Particularly, it's more common in young adults or children, and we can look for the symptoms of this, which is unilateral nasal block, nasal discharge, postnasal drip, and if they are large and protruding to the nasopharynx, may cause obstructive sleep problems. By examination, it's not usually visible with anterior endoscopy. It needs rigid endoscopy for assessment. We can see the polyp with the usual criteria of the polyp, which has a smooth gray glistening surface with surrounding thin serous mucus production. We can see it in the middle meatus if it's small, and more usually we see it in the nasal cavity, and we can trick it back to the choana, or sometimes if it's protruding to the nasal or oropharynx, we can see it through the mouth with the bottom of the polyp just behind the soft palate. The CT scan is a gold standard method of investigation, like nasal polyposis. This picture here, we see opacity in the left maxillary sinus, filling the whole sinus and protruding out of the ostium of the sinus to the nasal cavity. It's only surgically treated. There is no effective medical treatment towards antrochoanal polyp, and the surgical treatment consists of doing endoscopic sinus surgery in form of removal of the polyp. We should remove whole the polyp without any remnants, so as to avoid recurrent antrochoanal polyp. And we do wide ostium of the maxillary sinus. In cases with recurrent antroquinal polyps with multiple recurrence, there is an operation called Caldwell-Lock operation. This operation consists of sublabial incision, mucosal incision, and then having a bone opening in the anterior wall of the maxillary sinus, so it's anterior anterostomy, and direct removal of the polyp from the sinus. This surgery is not commonly used these days, especially with the development of the endoscopy and having all the angled instruments that can explore whole the sinus and remove any parts or remnants of the antroquinal polyp. Thank you.